Okay. Good morning. My name is Bonnie Gaughan Bailey, and I serve as the Deputy Director over Public Health Research. And today is Florida Health Grand Rounds. We are excited to welcome Dr. Otis Kirksey today as our speaker. But first, a few things before we get started. All phone lines are muted. Please enter questions into the question box on your control panel. We will have time for questions and answers at the end of the presentation. For your convenience, the slides from today's presentation can be downloaded. Click on the PDF file located under the Handouts tab on the control panel on your screen. For those who'd like to receive nursing continuing education credits, please fill out the survey that will pop up after the webinar. Make sure to enter in your correct license number. Today, I would like to introduce Dr. Ed Clark, who will be introducing our speaker for today. Dr. Clark is a public health scientist in the Bureau of Chronic Disease Prevention and the Division of Community Health Promotion at the Florida Department of Health. He is working to expand the availability of participation in the National Diabetes Prevention Program and the Diabetes Self-Management Education and Support Program throughout the state of Florida. Dr. Clark?
Good morning.
Good morning.
Thank you for the introduction, Bonnie. And good morning all, and welcome to the March 2021 Florida Department of Health Grand Rounds. It gives me great pleasure to share with you some of the excellent work taking place in the Bureau of Chronic Disease Prevention, notwithstanding the challenges presented by the ongoing COVID-19 public health emergency. Through our cooperative agreements with the Centers for Disease Control and Prevention, CDC, and the National Association of Chronic Disease Directors, NACDD, we have continued to implement evidence-based programs that address the incidence and prevalence of type 2 diabetes and prediabetes in Florida. According to the CDC National Diabetes Report 2020, 34 million Americans, just over 1 in 10, have diabetes, and 88 million American adults, approximately 1 in 3, have prediabetes. Furthermore, new diabetes cases were higher among non-Hispanic Blacks and people of Hispanic origin than non-Hispanic Asians and non-Hispanic whites. Diabetes is the quiet epidemic taking place in America. The Bureau of Chronic Disease Prevention is working with CDC to reverse the epidemic by helping to identify people with prediabetes, prevent type 2 diabetes and diabetes complications, and improve the health of all people with diabetes. Those efforts include the CDC-led Diabetes Prevention Program, our our National DPP, that provides the framework for type 2 diabetes prevention efforts in the United States. Through the National DPP's Evidence-Based Affordable Lifestyle Change Program, adults with prediabetes learn to make healthy changes that can cut their risk of type 2 diabetes by as much as 58%, 71% for those over 60 years of age. More than 1,500 CDC-recognized organizations offer the National DPP Lifestyle Change Program, 73 of which are in Florida, and more than 400,000 eligible people have participated. Since 2012, nearly 15,000 people have participated in Florida. Approximately 40 commercial health plans provide some coverage for the program, and Medicare began reimbursing for CDC-recognized in-person programs in 2018. To prevent serious and costly diabetes complications, Florida is working with CDC to improve access to diabetes self-management education and support, or DSMES, with an emphasis on DSMES programs that meet national quality standards. The Bureau of Chronic Disease Prevention implements the National DPP and the DSMES via our Disability and Health and Diabetes programs. In 2018, the Disability and Health Program piloted the CDC-approved Type 2 for All National DPP curriculum developed by the Lakeshore Foundation. The curriculum is unique in that it is designed to be inclusive of persons with mobility and/or sensory disabilities. We have since adopted the curriculum for all of our state-sponsored national DPPs. Our work is made possible by our many partnerships with our county health departments, the Departments of Education and Agriculture, the Florida Area Health Education Centers Network, and federally qualified health centers, which brings me to today's guest speaker, Dr. Otis Kirksey. Dr. Kirksey received a Bachelor of Science and Doctor of Pharmacy degrees from Florida A&M University. He is a retired professor of pharmacy with over 25 years of experience in academia, with specific focus in the areas of pharmacy practice, diabetes, and primary care. His experience as a practice pharmacist spans nearly 35 years and encompasses a variety of practice settings, including hospital, community, and ambulatory pharmacy practice. Currently, he serves as Director of Pharmacy Services at Neighborhood Medical Center, Inc., a federally qualified health center. Dr. Kirksey was recently awarded with the distinction of Professor Emeritus of Pharmacy Practice by Florida A&M University College of Pharmacy and Pharmaceutical Sciences. He is board certified in advanced diabetes management and a certified diabetes care and education specialist. He is also a certified lifestyle change coach, as well as a master trainer of lifestyle change coaches for the National Diabetes Prevention Program. Dr. Kirksey has received funding for research from federal and private sponsors, including the Centers for Disease Control and Prevention, the Department of Health and Human Services, the National Library of Medicine, and the Minority Health Professions Foundation. Dr. Kirksey has authored or co-authored over 20 manuscripts published in refereed and unrefereed journals and newspapers. At present, Dr. Kirksey serves as President-elect of Healthcare and Education on the Board of Directors of the American Diabetes Association. He is a member of the Kappa Alpha Psi fraternity, the Sigma Pi Phi fraternity, and serves as the director of the Prince Hall Shriners National Community Health Initiative. Please join me in extending a warm Florida Department of Health welcome to my friend and colleague, Dr. Otis Kirksey.
Good morning. Thank you so much, Dr. Clark, for that introduction. It is indeed a pleasure to spend a quiet hour with the Department of Health talking about a topic that's near and dear to me. This morning, I plan to discuss overcoming barriers to improve outcomes in uninsured patients with diabetes. I'm so impressed with what the Department of Health has done statewide to improve access to self-management education as well as the DPP program. Those programs help to save lives, prevent morbidity and mortality. Having said that, I'd like to move on into my presentation. So this morning, I'd like to discuss with you over this hour. Hopefully, we'll be able to identify some factors related to barriers that impede glycemic control, and as well as other therapeutic indicators as it relates to patients with diabetes, which include those that relate to blood pressure control as well as liver control. We're talking about factors that contribute to therapeutic or clinical inertia that often delay positive diabetes outcomes. And then finally, I just want to give a shout out and share some interesting things that the American Diabetes Association is doing to address health equity among patients with diabetes. This is very interesting because actually COVID has really demonstrated what divide we have in terms of the parity of healthcare, people of color, communities of color, as well as socioeconomically disadvantaged populations. So as Dr. Clark mentioned earlier, we have over 34 million people in the United States who have diabetes, and 1 in 5 don't know they have it. And that's the dangerous part about this disease, is that oftentimes when patients are diagnosed, they're already demonstrating some long-term effects of the drug. And so clinicians or providers are always chasing the tail of diabetes, we're always trying to catch up because so much damage has probably already been done. The 122 million live in the United States with prediabetes, and another 1.5 million each year are diagnosed with the disease each year. As we mentioned earlier, people, communities of color, African Americans, are nearly twice as likely to be impacted by diabetes than their white counterparts, and as well as experience a disproportionate impact on the morbidity. So, we all know that diabetes costs a lot of money, over $327 billion annually. And so if you look at the cost of healthcare is nearly 2.5 times higher for those with diabetes. So, I mean, diabetes can actually, make or break a family. Patients struggle all the time to pay bills because of the cost of diabetes care. People with diabetes account for $1 of every 4 spent on healthcare, and that's tremendous. Those who are on insulin, 1 in 4 insulin dependent people, and that doesn't necessarily mean they're type 1 or type 2. These are patients who depend on insulin to control their diabetes. They're rationing their supply. So if you extrapolate out what is a potential impact for that could be death. It could be hospitalization. It could lead to amputations and so forth. Nearly 1/3 of those patients report not self-monitoring blood glucose levels. And this is really one of my pet peeves. And, because I always tell my patients, you can't drive if you're blindfolded. Self-monitoring blood glucose is a tremendous tool in the overall management and control of the disease. It gives patients direct feedback in terms of how well they're doing, what impact foods have on their blood glucose levels. 1 in 3. Can you imagine? What about those patients who are on basal bolus insulin therapy? Can you imagine them using an insulin and not monitoring their blood glucose? The whole thought makes me extremely nervous. So we all know the consequences of poorly controlled diabetes. It's the primary cause of death for 80,000 people every year. Every 4 minutes in America, a limb is amputated due to diabetes. More than 60% of non-traumatic lower limb amputations are a result in people with diabetes. And consistent with many patterns of inequities and disparities, people of color are twice as likely to experience those amputations. Diabetes is a major cause of blindness, kidney failure, heart attacks, strokes, and more. But the great news is that we have strong research evidence that demonstrates that these things don't have to happen. They can actually be prevented or delayed. And so that's with control of the disease. But how do you get control of the disease when you have so many other factors that impact your ability to get to that point? A profound factor are those that relate to social, economic, and environmental barriers. And so, these slides right here are actually graciously provided to me from information I received from the American Diabetes Association. And basically what they have found is that the prevalence of the disease is inversely related to household income. So the higher the amount of money, the higher income, the lower the rate of diabetes. And that makes sense because if you can afford uh, access to care, if you can afford to eat the right things, if you have the right environmental factors around you, then your chances of developing disease are going to be lower. Living in poverty in the 2 years prior to diagnosis increases the risk of type 2 diabetes nearly 25%. And so this is really interesting because I was watching I guess one of the news shows last night, and they were talking about how the pandemic had impacted people. And you have folks who were working, were eating healthy diets and so forth. And after during COVID, they lost their jobs. They began to eat more rice and carbohydrate rich type foods because they're cheaper and they go longer. And so you can imagine what the impact in terms of the diabetes population is going to be in terms of as a result of COVID alone. So diabetes risk also inversely related to the amount of green space in a person's neighborhood. You got space to walk, take a walk in the evening. Is it safe? Is there a park to go and play? Is a park to go and walk and so forth? 1 in 5 of the chronic disease patients report having experienced discrimination in healthcare. And this is not always overt discrimination. I mean, that is very important because these are kind of things that impact people's willingness to engage in the system. So let's talk a little bit about another barrier, which is self-efficacy. And the theory of self-efficacy proposes that patients' confidence in their ability to perform health behaviors influences which behaviors they will engage. And so it's hard to separate all of this because if a patient is impacted by the social, economic, environmental factors you mentioned before, how do you think that's going to impact their self-efficacy? And so, in terms of managing the disease, we have to address all of this. We have to provide that patient with the kind of education that empowers them to feel that they can take control of this disease and that they can problem solve and go and maneuver around all the barriers that can potentially impede their success. Another important barrier is therapeutic inertia or clinical inertia. And this is a topic that has recently been discussed a lot. It is the failure of healthcare providers to initiate or intensify therapy when indicated. And this can be related to contributed by patients. It can be contributed by providers as well as the system. What are those things that prevent you from making uh, quick decisions in terms of changing therapy so that ensure that you get the patient to the outcomes that you're looking for? And so you think about a patient who has just been diagnosed and you start them on the medication regimen. Therapeutic inertia would be, seeing that patient 3 months later when therapeutic interventions could have taken place a month earlier, to identify problems with the therapy, any side effects, even determine whether or not the patient received the medication. And so there are a lot of factors that contribute to therapeutic inertia, and this is a very important barrier that should be addressed. How are we initiating or intensifying therapy? How often do we do that? How often do we assess how well our patients are doing or whether the barriers are preventing them from getting there and going in and changing those things? Right along with the inertia is the diabetes distress, which is the emotional response to the burdens of living with diabetes and the self-care necessary to manage disease. Diabetes is an overwhelming disease. It's easy to get burned out. You're checking your blood sugar every day, even pricking your finger. That's burnout. It's uncomfortable and people get tired. And so you can see how diabetes distress can actually interface with lack of self-efficacy and the influence in the face of the influence of those social, economic, and environmental factors to create a cocktail that is almost impossible to get around. And so it's important that you'll see some of the things that we do at Neighborhood Medical Center to identify some of those things so that you can begin to address them so that you ultimately get to the outcomes that you're looking for. So at Neighborhood Medical Center, as Dr. Cloud mentioned earlier, it's a fairly qualified community health center. Yeah, we provide primary care, chronic disease management, mental health, dental care, and we have access to specialty care, pediatrics and psychiatry, as well as case management. And all of these entities play a role. All of these entities are our patient, a lot of our patients are engaged with, particularly when you're dealing with the mental health, the dental care, case management, and as well as the specialty services that our patients often need. So I don't know if you can see that. It's kind of small on my screen, but this is just give you kind of a demographic profile of our patients. Majority of our patients are between 18 and 64. Most of them are African American, and our Hispanic Latinx population community is growing. Income, most of our patients are at or below 200% of the federal poverty level. Most of them are uninsured. Those who are either Medicaid or Medicare, and a significant percent of our patients live in public housing. Now, I just want you to think about let that resonate with you for a little bit. So you can almost look at this patient profile, and you can almost identify what are those barriers are going to be. And so this group of patients are oftentimes they are in most need of quality diabetes management care, and they're often least likely to get it. So at a neighborhood medical center, we some of the selected chronic diseases. This is from some of our UDS data. 23% of our patients with hypertension, 27, almost 30% of our patients with diabetes, significant percentage greater than 9% A1Cs. So you see that we have our hands full in terms of the patients that we address each day. So while we are not technically a patient family medical home have that status, we work as a team, and believe it or not, COVID has enabled us to work even better. Prior to COVID, we have a total of 5 locations. One of them is in rural Gaston County, in a small town called Havana, and one is based at one of the local high schools in the neighborhood, and the other 3 are located, 2 in the south side of Tallahassee, and the other one in the Bridgetown area. And so before, it was very difficult to be in 1 or 2 places at one time, but COVID has allowed us to utilize some telehealth. We can really collaborate a lot more often. And so our team consists of certified diabetes care education specialist, which is myself. I have a diabetes research fellow who is right now, due to the COVID, we suspended that particular position, but plan to pick it up in the coming fall. I have a physician provider who actually works with me, as well as our medical director. And then we have nurse practitioners, medical assistants, mental health counselors, and all of these individuals play a very important role. I leave our case management because that piece is probably the most important. Our patients require a lot of case management, just maneuvering through the healthcare a maze, takes a lot of lift, a lot of stress off our patients because of the action of our case managers. We incorporate disease management for type 1 and type 2 patients. We also pay close attention to those with hypertension and hyperlipidemia because we know that a significant number of people with diabetes die from cardiovascular related diseases. Our program is evidence-based. We do one-on-one patient encounters. At one point, we used to do group classes. You can educate a lot of people that way. However, it's very difficult to address individual issues in group settings, and so there also does some billing limitations to group with federally qualified community health centers. And the service is referral based. So patients must go through their primary care provider before engaging the diabetes self-management education program. We typically provide 2 levels of services. First, all patients with a diabetes diagnosis that come through according to our diabetes quality care plan must be referred for general diabetes education. It's amazing how many patients who've been living with this disease for 5, 10 years and have never ever received formal diabetes education. The second level is disease and medication management. And this is often involves patients who are more complicated, patients who come in with A1Cs unmeasurable, patients who are non-compliant, patients with multiple comorbidities. And so oftentimes providers will refer the patients to me, and because I can see them more frequently than they can, and can make those necessary recommendations for therapy changes quicker than they, thus reducing the inertia associated with that. So our initial visit is 60 minutes, and oftentimes it goes over that, depending on what's going on. We try to, prior to that visit, we have patients complete a couple of assessment instruments, and I will let you, we'll go over that in a few minutes. But initially, at our first visit, getting ready, we review the medical history, the lab results. Again, we have them complete the self-assessment questionnaire, which gives us an update in terms of, exactly what they need. We try to identify what the education needs and deficiencies are, as well as identify disease management priorities. We developed the diabetes education plan, and hopefully we attempt to complete the initial education session there, as well as identify potential referrals for specialization. For instance, if a patient comes in and the patient have issues related to mental health, many times that might abruptly, that visit may be abbreviated to get that patient in with the mental health counselor to deal with something that's way more urgent, because diabetes self-management is impossible with someone who has uncontrolled depression or anxiety or other mental health issues that are not being controlled. And then finally, we document everything into our electronic medical record. The follow-up visits are 30 minutes, and oftentimes we are coming in, we're reviewing any labs that may come in. Again, if we did not get a chance to complete any of the activities from the first visit, we'll go ahead and take care of those things. We will assess, establish goals, as well as determine whether or not we need to make any changes to our plan, as well as refer and so forth. So it's like a cycle uh, but much faster. Excuse me, I'm in my home office, so all right. So the next, so this is a schematic diagram, kind of shows what how our patients flow through our program. As you see here, you get initial referral to the program, and then we do those initial assessments, which is the diabetes questionnaire. We look at their labs. We do a diabetes self-management assessment. We do a diabetes distress assessment. We review the medical history, and all of that assessing will kind of guide us in terms of where that patient needs to go. If there is a hard stop in this assessment area that may lead to a case management needs, may lead to a patient going back to primary care, then those kind of decisions are made there. Once we get through assessment, we can then begin to determine what the patient's selected behavioral goals are as relates to the disease, and which leads to our care plan being implemented. And then there is always a continuous piece of assessment. And sometimes it's just like a cycle going back and forth. You assess, you intervene, you assess, and so forth. So I mentioned assessment. Some of the key assessment tools that we use is the diabetes self-management questionnaire, which is a 16-item questionnaire that assesses self-care associated with glycemic control, and it evaluates them in 4 different areas: glucose management, dietary control, physical activity, and healthcare use. And the instrument allows you to get an overall score as well as a individual score for each area. And so it's basically what I've done is I've created a spreadsheet, Excel spreadsheet, in which I can put the data into the spreadsheet. It calculates the score and gives me a summary of those scores, so I can easily identify what areas we really need to concentrate on with that patient. Another key instrument is the diabetes distress scale. And this is a 17-item scale that captures 4 critical dimensions of distress: emotional burden, regimen distress, interpersonal distress, and physician distress. And so all of these areas are very key because, as I mentioned earlier, patients' level of confidence is impacted by the, diabetes distress. So we have to identify that. We oftentimes find that the stress or the distress is coming from home. They are overwhelmed. We have women who are trying to prepare 2 different meals every day because the husband or the kids don't want to eat the foods that they should be eating, and she's trying to do right about her disease, and so she's got to go home and cook 2 meals after working all day. Or the physician distress, where patients interpersonal relationship with their providers, cause distress. Yes, we can also be a source of distress with the patients, and that's why it's important that we assess ourselves and put ourselves in check and make sure that we're delivering the kind of care that we should be delivering. Our therapeutic targets are consistent with those that are recommended by the American Diabetes Association. An A1C of less than 7 is typically our a goal. However, remember I said everything is individualized. Individualization is key. So an A1C of less than 7 for a 45-year-old man with diabetes with limited comorbidities is just not aggressive enough. And so, we may set an A1C less than 6.5. And once we reach that goal, we establish another one. And so we've been successful in some cases. We have patients who A1Cs are 13, and we've gotten A1Cs down to 5.9. So it can be done. On the other hand, I have a lovely 88-year-old patient who is Swedish TB. I'm not setting an A1C of less than 6.5 for her. We've established a generous A1C goal of between 8 and 7.5. The more aggressive you get with your glycemic targets, the more risk for adverse events such as hypoglycemia. And an 85-year-old patient who develops hypoglycemia could likely fall and break her hip and totally end a otherwise life of independence. And so you have to make sure that you select the right targets. Or a patient who already has serious comorbidities, already had a stroke, 2 heart attacks, maybe already in has chronic kidney disease. So you have to be realistic in terms of what targets you're going to pick and make sure they are ones that your patients that are not going to uh, expose your patients to unnecessary risks. So our overall goal management plan is to decrease progression of disease and improve quality of life. And so the goals are individualized, interventions are individualized, the lifestyle interventions are individualized, and as well as the self-monitoring. So quite naturally, nutrition education is an important part of our program, and it's probably the one that people ask for the most. Oftentimes, though, their ability to comply is impacted by those socio-economic factors that we mentioned earlier, and so patients oftentimes want to do the right thing, but they're often impeded by those barriers. But we are able to use food models when we were doing disease management face to face and not through telehealth. I had three-dimensional, food models that we would use, and we still try to use some of those now. But we also use nutritional materials from the American Diabetes Association, as well as educational materials that are provided to us by pharma, which some of them are very good. We have educational materials that are in Spanish, and there are also some apps that we use that can actually convert some of the stuff to other languages. When that I've actually found these apps on the internet in terms of other languages such as French for some Creole speaking patients and so forth. I like to use MyFitnessPal because those patients who have smartphones, it's a good way to empower them with ready access information on carb content of foods, caloric content of foods, and so forth. And the other thing is they can also track their physical activity as well as their weight using the MyFitnessPal app. Our lifestyle interventions typically generate around a basic 150 minutes of physical activity per week. We try to get them to do a mixture. I had a patient yesterday, all he wants to do is lift weights. Try to encourage him, you need to do some cardio as well. We also, you have to make sure that patients have an environment. I always ask patients, do you live where where it's safe for you to walk? You don't want people walking and there are no sidewalks. There's a heavily trafficked road with cars and so forth. We have patients also who have arthritis or they have neuropathy so bad that they can't do those kind of things. And so we talk about armchair exercises, and I can, give them copies of recommended activities that can do. Or they may have cardiovascular or pulmonary diseases that limit their exercise tolerance. So we have to make sure that whatever recommendations that we make, that is considered is consistent with that patient's limitations. So this is really the area that I'm most excited about in terms of management because I am a pharmacist, but we have so many great therapeutic options uh, for our patients, particularly with type 2 diabetes. Type 1 diabetes, it's insulin. And we have analogs that are available now that have great absorption, they have longer acting, less hypoglycemia associated with them. And so with type 1 patients, it's pretty easy. With type 2 patients, you're dealing with so many different factors that contribute to hyperglycemia. However, now we have drugs that impact all of those, most of those areas. And so the older drugs that we used to use, that we used to see a lot, the sulfonylureas, drugs like glimepiride, glipizide, and so forth. Those drugs are they're and I talked about them earlier. One of the challenges of the older drugs are associated with more side effects. They're also associated with weight gain. Okay, and so people with type 2 diabetes most often are trying to lose weight. But the newer drugs that such as the GLP-1 agonists, you've heard drugs like Ozempic, drugs like Trulicity. These groups of drugs have been found not only to provide excellent coverage in terms of glucose control, but they also help patients lose weight, and they also provide significant cardiovascular protection. So it's like having your cake and eat it too. No risk of hypoglycemia associated when you use these associated with these drugs. The DPP-4 inhibitors would work on the same system as the GLP-1 agonists. While they don't cause weight loss, they are weight neutral, and so you don't have to worry about a patient gaining weight. When you put patients on sulfonylureas and insulin, it's almost impossible for them to lose weight because the drugs themselves make them gain weight. Our other big area are these SGL2 inhibitors. Drugs like you've heard as Jardiance and a few others. I guess my age is showing. But this particular group of drugs actually work by making the body force the glucose through the urine. So you're urinating out the glucose. And so no hypoglycemia. These drugs have been found to not only cause weight loss, but they also have an impact on blood pressure. Okay? And so oftentimes we have to adjust the patient's blood pressure medications because of that. And then they have significant prophylaxis for cardiovascular complications with these patients. Again, all these drugs have common side effects. With the GLP-1s, we have to worry about nausea and vomiting because the way they actually slow absorption of the food in the gut, and so patients who overeat can experience nausea even more. The direct contraindication if they have a history of thyroid carcinoma, you definitely don't want to use those. With the SGL2 inhibitors, you're thinking about patients having, particularly women or uncircumcised men, because the urine is so rich in glucose, they can actually experience yeast infections. So you have to make sure you counsel those patients to make sure that yeast infection does not be a cause of that patient stopping the medication, which is another form of another problem that can prevent us from getting where we need to go. So when we look at our formulary management, which is very important, I kind of mentioned some of those things earlier. We look at the affordability of in terms of these are our go-tos, patients who are uninsured. The sulfonylureas, the biagonazole metformin, TZDs, thiazolidine diones, and the human insulin, regular NPH. Now, as I mentioned earlier, these are affordable, but they often have side effects that kind of restrict their use or limit their use or make their use more problematic. I mentioned earlier about sulfonylureas, weight gain, hypoglycemia. With metformin, there are certain patients with certain renal dysfunction will not be able to use metformin, and it's associated with a lot of diarrhea, and some people just will not tolerate it. And you will recommend that for them, and they'll pick it up, they'll start it, and they'll stop. And so, you come back at the next visit, you think they have started, the medication is doing good, and they just can't tolerate it. The human insulins uh, are better than the older insulins, but the human insulins also have issues with absorption. And the NPH has a very nasty peak. And so if you're giving it before dinner, patients will bottom out around 2 o'clock in the morning, causing, significant hypoglycemia and so forth. Those are problems. With the regular insulin, you got to wait 30 to 45 minutes after you inject before you can eat. So it impacts quality of life. And so those are kind of things. With the other things that we consider in terms of the secondary benefits of our therapeutic options. And I mentioned earlier in terms of the GLP-1 agonists, I told you that in terms of what their secondary benefits were. The insulin analogs are much more safer, less hypoglycemia. The long-acting ones like insulin glargine and Detamir, they don't have peaks, meaning that you have to worry about that 2 o'clock peak, 2 o'clock in the morning peak, which contributes to hypoglycemia. The absorption of these drugs are spot on and much better and much predictable. And the rapid acting insulins like insulin aspart, you only have to wait 5 to 10 minutes. So you can inject 5 to 10 minutes, you can eat. Okay, so the other piece that we do, and I see my time is running out, so I'll run through, is that through our 340B program, we are able to access some of these new drugs, like the GLP-1s, the SGL2 inhibitors. We can actually obtain some of those drugs if they're on this program. We definitely, for the newer insulins, the analogs, we can get a month supply of the Levemir, Detamir, or the Novolog for our patients pay about $15 per month supply, which is unbelievable. Okay, and so we also have access to the DOH insulin distribution program, but however, this program only limits the use of the human insulins, and I mentioned to you some of the challenges in terms of using human insulins. And then we're also able to use a patient assistance program, which the manufacturers actually will send our patients 3 months of drug at a time. Some of them will mail it directly to the patient's home. Others will mail it to the center. This program is facilitated through our case management group, they actually do applications for the patients and they follow up to ensure that the refills are submitted in time for the patients to get their next 3 months supply. So when we look at the challenges, I mentioned earlier, we talked about the barriers. The patients are the patients. You got to meet the patients where they are, and you have to expect it. A lot of times we lose patients to follow up. I had a patient recently. I saw her last year. Her A1C was 6.1. I saw her just last week. Her A1C is 14. And so how do you go for 6.1? Well, I know COVID. That's exactly what it was. So those are some of the things that happens. Or in terms of language barriers, I mentioned earlier in terms of percentage of our patients who are Spanish speaking, And so I always feel somewhere inadequate when I'm trying to educate them, even though we have staff who speak Spanish, and other times they bring their family members to help translate. You always feel somewhat inadequate when you're not able to really relate. So, it's about trying to, learn about the cultures, understand them, and respect those cultural beliefs that those patients bring with them. Uh, Programmatic challenges, well, space, uh, time, you wish you could see all the patients. We are funding, and you can always have more money, particularly for my fellowship program. And a key shortage is that we do not have a registered dietitian on staff yet. That is significant because you know my strengths are disease management and medication management. It's not nutrition. And so while I can contribute a limited, service, it's not like having a registered dietitian to kind of take charge and lead that discussion. So those are some of the things that we're dealing with. And as I mentioned earlier, COVID, I think COVID is challenging everybody's program. I won't go through these. We basically did a survey of patients. We surveyed about 100 of them, and we doing good. And so we went through each one of those. We read the comments and so forth, and you make changes. Sometimes you'll be surprised at what you read, and so you say, "Well, man, I didn't think about that." So it's very important that you do self-evaluations to determine how well you're doing what you're doing. I'm going to skip here further and kind of get to. I just wanted to just update you in terms of the ADA Health Equity Now program, and it's concentrated in like 5 areas: cure, ensure that diabetes research better accounts for risk. I can barely risk-facing communities of color, and a lot of this, as I mentioned earlier, originated from this whole COVID situation. Cost, and I won't go through each one of these, but if you would like more information on the Health Equity Now, please email me and I can send some of that information. The hour went by pretty fast. I want to stop so I can at least entertain some questions. Thank you.
Thank you, Dr. Kirksey. Your presentation was filled with so many resources and ideas that can help us throughout this stage. We have a question that I'm going to read it. One of the education needs and deficiencies identified is the lack of cooking skills and not knowing how to grocery shop for healthier ingredients when shopping with food stamps. What are your thoughts on providing cooking instruction, grocery store tours for this population? And how would such an understanding be funded? Undertaking.
That is a great question. And actually, there's a group, Help Me Nutritionists out of Orlando, who are the authors of the Soul Food Cookbook. They actually have a demonstration kitchen, and they're doing exactly just that. They meet with the patients and they take them grocery shopping. That is huge. That's on my wish list is to have a teaching kitchen. Because what I found is that now we did partner with last year we partnered with the TMH Diabetes Center, and we actually brought in some nutritionists. They actually uh, demonstrated preparation of some salads and things like that. But I think it's so important that when you do those kind of things that it's culturally appropriate foods that you're using. You got to teach people how to eat foods that they're going to enjoy. And so teach them how to cook the collard greens with the smoked turkey or with chicken broth and not with the pork and so forth. Or, teach them how to oven fry the chicken so that they don't have, so they can still have fried chicken once in a while, but you're not dealing with deep frying it. Or how do you go to the grocery store and identify foods that meet your pocket, but at the same time uh, does not conflict with what you should be doing to manage your diabetes. And so, we always talk about, well, you need to eat, lean meats. Well, we know a chicken breast costs more than a chicken thigh, period. Okay. So, we have to be realistic about that. But I think that is a tremendous project that we should look at, because that could be the game changer. Because people are afraid about making change. When you start asking them about what kind of foods they eat, and you ask them about asparagus, I don't even know asparagus. But I could guarantee you, I could roast some asparagus with some tomatoes and some garlic, and once they tried it, they're sold. So you have to teach them how to do it. You have to show them that and encourage them to try things new. And it may not be just the patient, but you got to bring the family members in too, because as I mentioned earlier, it's expensive to eat healthy, and it's even more expensive when you're trying to cook two different meals. So I think the family environment is very important to add to that. Thank you.
Thank you. There's been some chatting that we can follow up with afterwards about some of the resources that you mentioned, the diabetes stress scale, the self-management questionnaire,
Yes.
and some of the pharma tools.
Yeah. What I can do, I can actually email you copies of those. They're very easy to use, but they provide powerful information.
Okay, great. And we can include that information along with your presentation on our Florida Health Grand Rounds webpage, so
Great.
that anyone can make those available. We'll also follow up with Dr. Clark. Okay, final questions. All right. So it seems that that the individuality of the care or the self-management plan is critical. What words of wisdom do you have for those who don't want to make that change?
Well, first of all, you have to meet the patient where they are, and you have to first demonstrate that you care. I have a slide on here that I always end my presentations that people don't care about how much you know until they realize how much you care. And so it's developing a relationship with the patients that get them to that point, and it's scary making change. And so small changes add up over time to big changes. And so I would say meet them where they are, small goals, small steps, and you can get there.
Okay, thank you. All right, and that was our last question.
Okay.
Let me just finish our grand rounds for today by saying our next presentation will be on April 13th at 10 a.m. and it's titled Periodontal Bacteria Augment Amyloid B in Human Transgenic Mouse Models of Alzheimer's Disease. And that will be presented by Dr. Casavallo. And the impact of periodontal bacteria and its impact on Alzheimer's disease. Okay, thank you everyone. We will have lots of resources, thanks to Dr. Kirksey, that we will put online. And remember that we record these, and so this presentation will be posted. on our Florida Health Grand Rounds site. Thank you to Dr. Kirksey, Dr. Clark, and everyone. Have a great day. Thank you so much.
Thank
Thank
you.
you. Have a good day.